So today I'm going to talk to you about, like mentioned, the gendered ethics of the transnational fertility industry and the future of reproduction or assisted reproduction, really. In my presentation, I will draw on my various ethnographic research projects on the transnational fertility sector, covering clinical practices, transnational mobilities, and the biotechnology and pharma industries. I explore it and have in my studies the sector's intersectionally gendered ethics, specifically through the lens of the reproductive justice framework and Avery Gordon's concept of haunting within the historical context of the Finnish Nordic welfare state trying at the moment to tackle the so-called fertility crisis. So the agenda of today, more specifically, is as follows. I will first mention about my project's background a bit, and then quickly visit the reproductive justice framework, and then moving on to the fertility industry trends integrated with the Finnish Nordic case. And finally, I will wrap up with discussion on just and unjust futures and presents of the sector. And this is also where I will bring out Gordon's concept of haunting. So my presentation, my talk is based altogether on 4 projects on reproductive technologies, clinical care industry, and ethics. 3 of them have quite recently ended, and 1 of them is ongoing, the one that Krista just mentioned. And my work is and has always been ethnographic and firmly grounded in gender studies, sociology, and feminist science and technology studies. And the ethnography data that I've been using consists of observations from fertility clinics, different sort of intermediary agencies, exposed gamete banks, and gamete banks, both in Finland and abroad. I also interviewed intended parents, Finnish ones going abroad for IVF, so in vitro fertilization, often donor IVF, and also intended parents coming to Finland for fertility treatments. I've interviewed donors, medics, embryologists, brokers, and other corporate actors in the field as well. Theoretically, in my work, ethical evaluation is approached both as a form of situated moral reasoning and as resonant with questions of social justice, specifically reproductive justice. Valuation is perceived as enacted in socio-technical and clinical practices, and at the same time, me and my team attend to the modalities of valuation that exceed this deliberate, conscious action, sort of an excess already implied in the term of valuation itself. For example, my projects explore and have explored affects as moral drivers or engines, if you will, moral atmospheres, and also these more elusive, haunting-like presences that permeate practices, organizations, and related institutional settings. Then a bit about reproductive justice. So reproductive justice, for those of you who don't know, is a framework which centers the human right to maintain personal bodily autonomy, to have children, not to have children, and parent the children we have in safe and sustainable communities and environments. Coined in 1994 by a group of Black women called Sister Song, Women of African Descent for Reproductive Justice, the notion of reproductive justice relates to broad issues in health and social care, including access to assisted reproductive technologies, but also policy reforms concerned with, for instance, human rights, child welfare, education equality, poverty, discrimination, and immigration, all of which are fundamental to the achievement of reproductive justice. The concept of reproductive justice positions reproductive rights discussions within broader social justice discussions. So it shifts away from an individual rights and choices discourse to a wider group of concerns over the conditions under which rights can be exercised. Generally, it uses an intersectional approach to draw attention to structures of inequality underpinning reproductive injustices. Generally, moving on to the sector itself, assisted reproduction is a highly commercialized sector. While some countries offer publicly provided treatments or reimbursed expenses, in most cases, people need to pay out of pocket, at least to some extent, or through private insurance, even in large redistributed welfare states of the Nordic type. Fertility treatments, especially IVF, involving donor reproductive tissue, such as gametes and gestational labor, are increasingly obtained from others as commercial services, also across national borders. To meet the increasing demand, the multi-billion euro or dollar transnational fertility industry recruits especially women as donors and surrogates globally. The transnational industry and the market are growing steadily. The markets are also being reshaped. Characteristic to the fertility sector is an ongoing expansion and the rise of private equity investments. Like Lucy van de Wiel has shown in her work, the reason for capital investors' interest is, well, of course, the expanding prospects, but also the fact that the fertility market does not respond to economic trends like many other markets do. So even if it is recession, people suffering from fertility disruptions wanting a child do not postpone IVF because they don't have the time to. Right. Other market trends include the significance of patenting and increase in consolidation. The move toward consolidation is manifest in the merging of fertility clinics into these larger transnational chains, the growing influence of online platforms in organizing fertility treatments, especially when it involves mobilities, and the portfolio expansion of the companies. Firstly, to incorporate each step in the fertility journey. Be with you, be together all the way, like with Life here on the slide, a big predominant biotechnological company promises. And secondly, to include a wider range of fertility products to attend to every critical detail on your journey to success, like Merck here, another big fertility product provider, advertises. These products, which include both pharma and devices, and which are ever increasing, range from embryo culture mediums to incubator technologies to so-called add-on technology, which can be added to treatment cycles for further assistance. Add-ons include tech such as, for instance, embryo glue that helps embryos attach to the endometrium, and time-lapse embryo monitoring and incubating technologies, which nowadays also include health data-driven AI components, as do, for example, facial matching technologies used for matching donors, gamete donors, and recipients at the clinics. This technology involves AI models trained on large data sets of facial images. The intended result is a child that physically resembles its intended parents, long considered desirable in assisted reproduction because it allows a family to pass as one which is genetically related. The use of this process removes the clinical labor, if you will, of hand searching for clinics seeking to secure a good match. Generally, in the field of assisted reproduction, artificial intelligence applications and related technologies have been hailed as potentially significant and groundbreaking, not least because they promise standardization and automation in IVF clinics. And we know that this is the precondition for scaling up and branching out in the fertility bio industry, as pointed out by Sarah Franklin in her groundbreaking work. AI data-driven algorithms promise all sorts of time and cost-effective, successful personalized treatments, and especially in IVF, appraisal and selection of high-quality gametes and embryos. There are also a range of products sold directly to customers, including all sorts of products such as self-monitoring apps for reproductive health and fertility, and even something as bizarre as fertility pants. As you can see, read there, they are pants that help you save yourself from the embarrassment of being half naked in front of your clinical team. You can hold your keys, your cell phone, your ID in them, and ice and hand warmers, and you can easily pop in your inserts, and at the same time, they are comfy, yet function as sexy shaping underwear that are fun out for a date night. So some functional pants, aren't they? Dr. Amy, who also calls herself the Egg Whisperer, and this is a patented name, is selling these pants. I am on her email list as I attended her egg freezing party with a bunch of other women already in 2016 in San Francisco, held casually at a cozy Italian restaurant with tons of foods and cocktails, like on a girls' night out, and not in this like clinic space. The transnational fertility clinical practice does involve a lot of mobilities and migrations. Intended parents, donors, tissue, technology, and professionals all travel. Key destinations for people outsourcing their reproduction, if you will, include Spain, the Czech Republic, and South Africa for egg donation. Denmark is famous for its Viking sperm. And commercial surrogacy is a big business in, for instance, Mexico, the United States, and formerly in Ukraine, although I do hear that the business is back up despite the war. I'm also aware that currently surrogacy agencies are very interested in South America, more broadly, and Africa. Because of changing legalities and production costs, so to say, a so-called one-stop surrogacy or even donor IVF, where a single clinic provides a gamut of services ranging from egg retrieval to surrogacy, are becoming rare. Clinics and brokers are devising ways to break down the entire process into various stages, which each stage being outsourced to a country with favorable or no regulation and low costs for procedures. For example, a transnational Israeli-born fertility company, Tammuz, that has branched out to the Nordics with a daughter company, Tammuz Nordic Surrogacy, offers egg donors from South Africa who travel to Namibia, where the eggs are retrieved. Fertilization and embryo culture are done either in a lab in Namibia or in Tel Aviv. Finally, the transfer to the intended mother or the surrogate is performed at a clinic in Cyprus for intended mothers, and Albania, Georgia, or US for surrogates, depending on which country has been chosen and afforded by the intended parents. All these procedures involved are often conducted by transnational fertility consultants who travel, just like donors, gametes, and intended parents, to produce all these white, Nordic-looking babies and families. And then still a bit more related to the field of activities of the fertility sector. So here on your right, you see some of New Life Company's traveling donors who all fit the Western beauty ideal now, don't they? Simultaneously, the ad, in my view, can be interpreted to ease any moral concerns the intended parents might have about exploitation of women in the global South or global East. Just look at those tanned babes having fun holiday in the sun and casually donating their eggs on the side as if it was not the intrusive medical procedure it actually is. Intended parents typically seek reproductive tissue donation that will assure phenotypic resemblance with the infertile intended parent, right? That is, they mostly wish to be matched with donors that share their ethno-racial background and personal qualities seen as biologically inheritable. So, and here on the left, you see a snapshot of Cryos. It's a bit old, but anyways, it's similar now. Cryos Egg Bank, America's internet platform donor database, which for its own part, right, enforces the desire and perception of inheritability of all kinds of qualities when you may choose all sorts of characteristics for your donor there. Reproductive technologies that allow intended parents to select desirable, often socially desirable traits in donors have, in fact, been thought of as a way racialization, and racism appear in today's society. Like Ruha Benjamin has argued, race and racism are mobilized not so much by top-down eugenic policies and explicit reference to race anymore, but by allowing, encouraging, or even obliging these consumer citizens to make normative racial genetic family choices like this, often also in the name of the best interest of the child. For example, I have in my data these white recipient intended parents who explain to me that they would prefer to have a white egg donor in the best interest of the child, who would then belong to the family more easily than racialized children in many respects. For example, for them, the choice of a white donor sort of seems to be authorized whenever possible. So they're not saying like, oh my God, I would never have a racialized child or donor, but if I have the choice, then I should. So that's how it kind of comes out. As it turns out, Finland, where I've mostly conducted my research, or in the context at least, Finland is part of these transnational markets in a curious way. Within the Nordic region, Finland is the destination for donor eggs, especially for travelers coming from other Nordic countries, namely from Sweden and Norway. And while we're not talking markets such like Spain or South Africa or Czech, in the context, a great deal of the Finnish donor eggs go to these fertility travelers. People come to Finland for Scandinavian eggs as if belonging to a historical, geographical, cultural area was somehow biologically inheritable, and disregarding the history where Finns have not always been at all perceived as even true Europeans or white, but yellow-skinned Mongolians. So what kind of presents and futures can we see applying the reproductive justice framework here? Let's start with access to care. So globally, assisted reproduction, reproductive technologies, they're not available to everyone equally. Sexual, gender, and ethnic minorities do not have equal access. The treatments are also expensive. And then there are always these geographical margins who are the global losers in terms of access to any resource right. Me and my team members, Gwen Zablell and Tia Sudenkarne particularly, have shown in Finland unequal practices regarding access to reproductive health and fertility services that exist toward people that do not easily conform to the ideal subject of the Nordic welfare, the historical ideal of a white middle-class heterosexual cis person in a romantic partnership. This does not mean that everybody else is denied access, but that reproduction is stratified in a temporal fashion. Most deserving of services are first served and served better, and latecomers like queer and migrant persons should wait for their turn whenever that may come. For instance, it was only a few years ago that trans people were not anymore required by law medical proof of sterility for legal gender recognition in Finland. Despite all this, there is this persistent color and class blindness in Finland, enabling invisibility of the impact of social status on access to healthcare and social support, on how some are encouraged and others impeded or discouraged to procreate. It's been argued that it is the powerful illusion of Nordic egalitarianism in concert with normative perceptions of white homogeneity of Finnish people that results in this blindness, as well as neglecting and hiding Finnish eugenic and colonial pasts. In the case of Finland, this relates to how Finland is a settler colonial nation taking over the indigenous lands of the Arctic area Sapmi and our colonial complicity regarding the great European colonialism. And also in the early 20th century, there was a period of open eugenics policies, racial hygiene policies, as it is more broadly also called in the Nordics. And these policies including the denial of social benefits, banned marriages, and compulsory eugenic abortions and forced sterilizations in the name of the good of the nation. Those deemed undesirable were the poor, the working class, the disabled, and populations minoritized by ethnicity, including the indigenous Sami people. The discriminating status quo today is justified as reasonable under conditions of scarcity, whether of finances or, for example, donor gametes. So the question remains for Finland, and well, I suppose globally, if access to fertility treatments and the treatments themselves are still tailored for privileged people on these racialized markets and often at the expense of the less privileged. The possibility of increasing resourcing of public healthcare that would equalize access is perceived often in Finland as impossible in the future of the Nordic welfare state operating within capitalism. This depoliticizes questions of resourcing. Such ideological closure, as Wenza has called it in our joint work, disappears the possibility of a demand for reproductive justice. The silenced histories and obscured unequal practices that exist, however, haunt our welfarist present, but hopefully not our futures if we could acknowledge the violence and stop the repetitive reverberation of violence across time. And here we apply Avery Gordon's unique theorization of haunting. According to Gordon, something is haunted when social violence has been suppressed and hidden, but is very much alive, troubling, and eerie. Haunting describes just those, and I quote, experiences to which the fixed forms do not speak at all, which they do not recognize. And yet haunting makes everything we do see just as it is, charged with the occult and forgotten past, unquote. We take Gordon's concepts of haunting and turn our gaze to the marginalized and the denied in the past and today, those whose fertility and family making are or have been allegedly in need of violent control and technological governance in a Nordic welfare state that, in the name of social inequality and universality, is not supposed to allow such things. Then let's move about to the reproductive justice point about not doing harm or doing harm. We know from prior studies that there is this cultural normative pressure for intended parents in fertility clinical practices to use whatever technology available before considering alternative non-tech options for parenthood. And the financial markets benefit from this, I argue. There's a trend for the capital investors to demand clinics to adopt ever more new technology and pharma. And then there's a trend for the investors to have their demands met in order to get better success rates. And I've encountered this in my fieldwork, for instance, fieldwork as well. And for instance, there's this demand to stimulate the oocyte production in donors with bigger hormone dosages than perhaps in the intended parents. And this is dangerous stuff, right? As this increasing intervention into the bodies of women and other people with female reproductive organs as donors and intended parents. AI and datafication have been seen as solutions here. AI has been perceived as providing more access via automation and streamlining. Further, AI models as data-driven technologies with more precision have been taunted as providing non-invasive and safer treatments in terms of physical but also mental health due to possibly less strenuous treatment cycles and medical intervention in achieving pregnancies. There is no evidence, however, that this will happen. Rather, as we argued together with Nikki Hudson and Neil McBride from De Montfort University, it is likely that AI-based reproductive medicine will be at least initially centered around a small number of big tech-savvy players providing services to the global north and thus not widely available, let alone in public welfare services, which tend to be the last ones to integrate IVF add-on technologies generally. Further, there's a risk that the data used by AI are not equally used to train the AI are not equally based on populations. And in particular, that individuals from minoritized and low-income contexts are not properly represented in the data because of historical stratification of reproduction. It is not far-fetched to suspect some groups and their reproductive cells could be done harm if treated with solutions based on data from advantaged populations, the white, the middle class, heterosexual couples with different kinds of reproductive health histories. How about reproductive autonomy? Autonomy in reproductive decision-making presents a challenge in assisted reproduction generally. Again, AI has been celebrated as offering people better control over their personal reproductive lives and decisions with the help of more precise medicine and pregnancy predictions. But that is only if we can trust the certainties that AI offers. Explaining the science of embryo selection and stimulation protocols in the face of the chronic uncertainties that characterize outcomes in IVF treatment, like generally, is difficult even with the unexplainable black boxes of AI in assisted reproduction. Groups who are traditionally marginalized from technology use have lower levels of health literacy. They may be further excluded from assisted reproductive treatments. Further, decisions to not use AI in assisted reproduction might not even be possible, as decisions to adopt these technologies tend to be administrative decisions rather than clinician or patient decisions. AI facial recognition use in turn in matching will potentially also reinforce normativities regarding family making in assisted reproduction, couple and heteronormativity, and the norm of biogenetic-like relatedness with racial and ethnic resemblance might determine family belonging even more strongly. We also need to keep... Oh no.
It's in the slide.
No, it wasn't supposed to put 2 at the time, but it's fine. I'll reveal my secrets already. So we also need to keep thinking about the ways to take care of the health and position of gamete donors and surrogates in bioethically unequal and very varied contexts and global networks. It is very different to be a surrogate in the safety nets of, for instance, a Nordic welfare state system, even today, than in like Mexico. Bioethical context matters so much. And remember what happened with the babies of surrogates when the Ukrainian war broke? They got stuck. And many others involved can get stuck in many ways in these global networks. However, be it Finland, the Nordic welfare state of Finland or Mexico or Ukraine, with third-party reproductive arrangements, donors and surrogates are emerging as these reproductive citizens to be governed by policy law and medical practice. And they are responsibilized morally for their behavior, health, and even genomics. And I've looked at this with my PhD student, Ronja. We involved the interviews mainly of the egg donors, and there is this, like the donors are clearly assigned these moral virtues where they must care for not just their own health and the health of their offspring, but also like care for the health of somebody else's children further along the line, like through their genomics. However, not all of them attuned to this sort of all-based ideal of a reproductive citizen. They're quite critical. And there are these sort of queer kin relations inactive, sort of providing these like alternative moral frameworks to think about donation, where sort of procreation is seen as a more complex process involving a compound of actors, like genetic actors as well, and then the responsibility becomes more shared or something. But anyways, what other kind of, there's hope there for sure. But because I've clearly screwed up this slide there a little bit, because this was supposed to come here, because I was going to first ask, so what kind of hope do we have for reproductive justice in the fertility sector now in the future? And well, there's resisting the all-based narratives. But like first about my conception of hope. So I understand hope here as something that requires that we must act in the present rather than simply just wait for the present that is always before us. So this Sarah Ahmedian type of understanding, not some naive or cruel optimistic views. And on top of sort of my resisting egg donors, my other example comes from looking at the clinics. There are these service providers that resist the mass industrial style. Together with Elina Helosvuori, we explored embryo culture technologies in IVF labs as approaches to a broader bioindustry of reproduction. Culturing technologies, well, first of all, they are designed to standardize and automate knowledge production regarding embryo viability. What we noticed about the everyday practices at the fertility clinics with Elina was that automation and standardization in clinical practice are not always perceived as even economically desirable, nor do they threaten the sort of skilled hands-on and experience-based local practice, although they may somewhat like transform it. And in such cases, concerns at the clinics were raised regarding the best interest of patients, embryos, and future babies and even generations who might be better served with masterful local craft work. And we concluded that embryo culture is not only a side of knowledge production, but also a side of multiple bioeconomies of assisted reproduction, some of which resist automation and standardization. But the consolidation trend does not in the sector, in the market, does not support the existence of these maverick ways and places. And to truly achieve reproductive justice in the field of assisted reproduction, any technology, AI or any other, will not provide the solution if it's built onto the existing, the foundation of the existing provision. Instead, we likely need a total reorganization of assisted reproductive medicine, which is largely commercial, like I said, globally, and with AI specifically reorganizing data economies and policies. And we cannot even stop here. As Rubin and Phillips point out, the cost and problems with access related to assisted reproduction is a distraction from addressing the basic healthcare needs, and we might add social support and education needs of women and other marginalized people, and the health management strategies which would substantially increase the probability of conception and reduce the need for medical intervention in the first place. Europe or the Nordic countries are not exempt from this. While many European welfare systems still provide for social support and equality, worrying transformations in social and healthcare systems have been observed over past decades, including marketization, decentralization, and deregulation in the name of cost cutting and efficiency. To change the normativities restricting people from forming families based on their lived and fluid ideas of relatedness and identity, we need a cultural change to change legislation, policy, medical practice, and data bias. And that's all I had for today. Thank you.
Do you have any questions? Thank you so much, Riikka. This morning in the New York Times, I read an article about dropping fertility rates in the United States. This seems to be a trend in many Western, so-called Western countries. Interestingly, young women are saying very early on that they are absolutely not going to have children. So do you see that this decision-making, if it carries through into their late 20s and late 30s, do you see this having an impact on the fertility industry? Do you see them, for example, ramping up advertising, AI or otherwise, to promote maternity for young women?
Thank you for that question. First of all, I think like the dropping fertility rates, it's globally. I think like it's only excluding like sub-Saharan Africa, we see this happening, and America, UK, United States was like for quite a long time it wasn't dropping, but now there as well. Women just deciding not to have kids, never for, like, if anything got better or stuff like that, they prioritize other things. Then I'm not sure they even know how big a group this is for sure everywhere, because like it seems that it's depending on the demography, the reasons seem to be different and I think, like, well, I know the Finnish case best. Like it has, they do like surveys on amongst young adults about, like, so why you're not having kids, and it has popped on. They're like, there are other things in life which is really interesting, but it's still not like just, and there's also that, you know, climate change. We cannot have kids, but the biggest deal is about not having a partner to do it with. Like, we don't want to have it alone, and it's also not having the financial situation to do it, or feeling too precarious in the financial situation they are. So it's like so many things, and it's also like it's people having less children than they would. So it's often like people won't have the second child. And in Finland, I think with these surveys, they've managed to sort of show that, like, generally, in the larger scale, people tend to have more children than they then end up having. So then it's the biggest group. It's not these people that decide that there's something else. And as women, we don't have to, you know, take on these roles that, like, despite, you know, all this work with that feminist movement has done, it's still more work for you and more responsibility and risk for yourself. It's an interesting idea for the fertility industry to start to, like, try to get this, like, not yet infertile group into, but they're doing it with like egg freezing already, aren't they? Like they are trying to, like, get this new sort of demography in of the not yet fertile women. And I guess in North America, you know, they have gotten women to do it a lot, whereas in Finland it's really minor.
It's really interesting because the New York Times will carry on the one hand an article about fertility decline, and on another page there will be an article about trad wives and how important it is to stay at home, read the Bible, and have as many children as possible. So it's again, we don't know about the numbers yet.
And the thing is also, but if the world was to change so that, like, people would just have kids earlier on, that would be devastating for the fertility sector, because they're depending on the fact that people postpone having children, and then they generally start meeting disruptions in their fertility and have to, you know, go for help.
Or inadvertently.
Rather,
you don't want to do it alone.
So that's better for them. I don't know if that didn't answer really your question.
We have a question online. So in terms of reproductive tourism and the differences in laws between countries, do you think that reproduction will begin to become standardized as its commercialization increases? Do you think the standardization would be helpful in improving health quickly or not?
Oh, thank you for that question. I wonder what they mean with standardizing reproduction, like everybody having IVF for the kids, or like having standardized technologies. The Zoom user would like to elaborate.
I don't know. You can unmute at least. They might be able to.
Like, so that's more like, okay, like standardized through different technologies. Well, that's the thing. It's we don't know. It probably. I'm skeptical, because it's usually whatever new technology will add on and some of the market. It usually brings up the costs rather than lowering them. I suppose we'll see with AI, but like at the moment, it is the big sort of tech savvy companies and the global north, and it's added, and it also is very different. Like, for example, in US, IVF treatments are much more standardized and streamlined generally. So it's freeze all, ixial, and if there is a time-lapse technology that nowadays have these AI components, like it's time-lapse all. But the price is massive compared to like Finland, where these are sold directly to the consumers as add-ons, and then they can take them if they want to. And obviously, that's not equality, is it? Like if you can't afford it and you do not have these in public care systems. So it's, and technologies alone, I just don't believe that they will ever sort of lead to health equality. Generally, that you need a more sort of like a systemic approach and then sort of, and apply them technologies then if you can. But standardization is a funny thing because it never really works either, does it? So it's like you bring a design, but people just don't use it that way. and so I don't know if that answers. I don't really have an answer. It will improve. Probably AI will bring us something, just probably not the sort of democracy in access and like everybody having a baby immediately when they want to. But it'll bring something, and it'll probably work well for, again, the privileged folk whose data is the one that's been used to train these technologies. So I don't know, I'm skeptical about standardization, but as a social scientist, I suppose I'm supposed to.
Okay. Hi, thank you so much for presentation. I was wondering about if you could actually talk more about your methods. Like you've mentioned that you've done a lot of ethnographic work. And have you done interviews with like fertility clinic staff? And what are some of the challenges that you see or you have seen around that?
Yes, so observations. I've also used video for the appointments and procedures and stuff, and then interviews. Well, access obviously is an increasing problem because there's really just been a change in power in the sector, in the sense that in 2014, when I first went to the clinics, with my first project, that was slightly different. But anyways, these clinics were owned by, of course, it was private clinics that I went to, not the public side. They were owned by doctors back then. Like they might even be like chains, but it was the medics who owned them and established them. But ever since, it's private equity that owns them. And the doctors don't decide about pretty much anything anymore. I think like I've had cases where like I've been sort of invited and they still will give me an interview, but like it's the board that decides that nobody's coming in. And for obvious reasons, I suppose then, but like that just adds on to like, okay, so you don't yourself think that you're operating really morally, and that's why I can't come in and stuff. So that's becoming more difficult to come there. But otherwise, I was surprised how the medical staff and embryologists and the intended parents really do tend to think that this is important research, and they do give you access. Did you have anything else?
No, but that's interesting. I mean, there's that's clearly a sign that money is involved.
So, isn't it? Yeah.
Yeah,
and different sort of money. It's like
so we're talking about financialization of the sector, which we're seeing,
it is financialized.
Like housing, sort of the same disease, if you will, but sort of where interests are completely different from the the people's interests. There's money interests, which dictates, you mentioned the increasing pressure to use technology, even if it's not necessary. So
because the stockholders do not understand medicine, and for some reason it doesn't go through their heads that like just adding more pharma and technology doesn't necessarily increase the success rate. Although success rates is a curious thing as well, because like it's not so clear cut. Like when they talk about success rates, they're not talking about babies that were born alive. They're talking about all kinds of clinical pregnancies and you can increase them with like multiple embryo transfers and stuff, which is forbidden in Finland nowadays, but like in like US it's not. So you easily increase with these like really dangerous multiple pregnancies. So yeah, that's the math that I've never really sort of understood. And they're kind of embarrassed to show it to me because like, well, the medics are like, I know that some of them are embarrassed that they're working for these chains, but what else are they going to do? Because that's pretty much all there is soon around, because it's tiny little private maverick places, they're eaten up like immediately. And yeah.
Is it okay?
Yeah, absolutely.
Question again. Riikka, you know that I really love your research and I'm really curious about your findings. I was fascinated by the graphic that you put up about the face and then the dimensions of the face being measured by AI to get a more perfect match. But of course, we know that there's genotype and there's phenotype. And when we're dealing with so many genetic components, we don't usually get what we think we're entitled to get. But I was wondering if when you're doing when you've done this research, are you seeing anything in the research or perhaps in the interviews where people are giving reasons that are, I suppose, perhaps evolutionarily based as to why they want their children to resemble themselves? I don't mean it in the way that you phrased it, which is so that it's easier for the child or it's easier for the family to pass, which I thought was a really great phrase. But could there be an evolutionary component? Or am I becoming right-wing now? I don't know. But do you know what I mean? There's some sort of a tribalistic desire on the part of humans to recognize one's own. I'm asking seriously.
Okay, well,
if that's in the literature, in like sociobiological.
yeah, that sounds like, yeah, like.
It's sad that I know two families, my neighbors actually,
Yeah.
who've done the same thing. And they specifically asked for whatever country they were, they wanted the donor to be from that country.
That country.
Yeah, in two different cases, yeah. So anyhow.
Yeah,
Totally.
I haven't come across that like in my data or somebody using that it's like some of the like evolutionary psychological thing that like just appears, but like, well, I wouldn't put it past people to sort of.
No, I wouldn't
think
either.
that. Yeah.
I think it should be taken more seriously.
And also it's like, especially with Finnish intended parents, because like, it has to do with like Finnish people's sort of like insistence on the social inequality, and like we don't have class, we don't have race, when it's actually there, and that kind of has been interpreted in literature as well, is resulting in the fact that like it's people do not want to talk about race in Finland. No, it's really just like it's like accusing them of racism if you ask them something about race. They talk in terms of ethnicities. And skin color. That like clearly is an implication of race, but it's just like you often get that if we ever had, well, it's also the illusion of white homogeneity, that like, oh, it's like few migrants, but rest of them are white. Yeah, no. And it's never been like that. But it's so strong. And if people talk to you about racism, they're just like, no, it's like it's few like populist right-wing politicians, and they're like crazy. And if we ever have racism, we don't have it anymore. And, there's all these like research popping out saying like Finland is the most racist country against especially the people with African descent in Europe. But yes, so that's also like, it's really subtle how I've sort of read that out of the stuff, that it's this like best interest of the child and fit better in is like, okay, like we can better raise a white child that comes off and also sort of like, oh, like then they don't have to confront racism And so we're just thinking this, how it sort of comes, why they should pick a
You also see this in
donor.
adoption,
Mm.
right? Where the
Yeah.
adoption agencies try to match as best as they can the ethnicity, race, etc. of the child with the adopting parents.
Yeah, and I think like without much critique, matching practice has been adopted from adoption practices, because of course this hasn't been going around that long because technology hasn't been out there. Yeah, and you can see a little bit like that in some of the sort of interviews I have about like, because of course there's in transnational adoption, and then it's the slogan about like, love doesn't, care about color. So it's kind of there. It's like, oh, like, of course we would like love to have a racialized child and love it and nurse it. But if we have a choice, we should do it because it would be better for the child.
Yeah.
Which is kind of like, okay.
Thank you.
Going like building on that, we had a project also on couples who choose a sperm donor to conceive their families, and the majority said the same thing, that they tend to choose a donor who looks like them. There's a minority, and I think I read that also in the literature, a minority of people who choose a donor who looks a little bit different from them to compensate something that
taller or shorter.
Exactly. Yeah. Or for example, one said like I tend to burn very easily, so the donor who's more thin than I am. But this is like a very like minority of people.
Does exist.
Yeah. And I think to your point, Christabelle, I think even as biological parents, we sometimes take pride in the fact that people tell us, "Oh, your son or your daughter looks just
like you." Yes.
Yeah, I don't know if it's like a narcissistic thing. I don't know what it is, but I think there must be something.
Yes.
Maybe we cannot generalize to everyone, but I think some people can relate to that.
Yeah.
So there must be something maybe deep.
There is. I mean, I'm asking, not from a sociobiological perspective, but to investigate this as a particular phenomenon. I have a friend whose sister gave birth because she was older and she used a donor egg and her husband's sperm. And when the baby was born, the baby did not have, of course, the eyes of the gestational mother, who was very sort of prominent blue eyes. And my friend, who was now the aunt of this child, said she found it so difficult when strangers, would come up to the child and say, "Oh, she has your eyes. She has the eyes of the gestational mother," but it would not be possible for that to happen, genetic trait. And she found herself feeling so uncomfortable because she felt she was participating in some kind of a deception, even though she knew that her sister really wanted a baby and was thrilled to have this baby. So I think it's extremely complex, and I think it's fascinating to explore. Yeah.
It is, yeah.
Any other questions online?
Let's say if you wanted, there's a sociologist who talks about white racism as a concept.
Yeah, that sounds cool, right? Yeah.
Just if you're interested in that, it's very interesting.
Thank you. Yeah.
We were speaking about.
Yeah. Yeah, and it's this. Yeah, it's subtle and it's integrated into these technological practices, isn't it? It's not your top down like explicit racist remarks or policy, but it's there. It's like and also like neo-colonialism and also neo-eugenics, in a way that like this is how you
Where do you want to go next with this research?
Oh my God. Yeah, well, the project that I'm now been leading for 1.5 years the AI is there, and it kind of grew out from the earlier project. So that's pretty much like where I am now, since there's still 3.5 years to go. Sort of to look at, so in that project, we specifically look at how new and emerging and technologies being modified sort of change or affect reproductive time and temporalities, understood as experiences of time, but also sort of how time is engaged in all kinds of social, technical practices and policies, if so, and how those like modified, if you will, temporalities have this gendered ethics. And I'm also interested in sort of justice questions, but also sort of normative ethics, gendered understood in very intersectional way. And specifically looking at 3 different socio-technical practices. We're looking at gamete freezing, cryopreservation, but also, other cryopreservation is of interest too. But like social freezing is there as well, because that's not been looked at in Finland like at all. And then the donation is still there because I have so much data that I haven't really written about yet, so I can bring that in. And then AI and related technologies and how those are very much integrated. And looking at those 3 practices specifically together and separately on the level of science, clinical practice, and the market, which, as we know, are so much entangled into each other in medicine that it's even sort of hard to not look at them all at the same time, unlike social science or maybe even law and history. So that's, I think my head is there for next few years, and we'll see what happens after that. I've been very much interested in sort of looking at the reproduction and environment nexus, but no funding so far. So we'll see. Now,
A trip to the University of
yeah, exactly. And being in Lapland, where of course the indigenous studies is a really big thing. I've only been there for about the same 1.5 years, and sort of this like and nowadays, like the indigenous studies seem to be taking at least their turn toward thinking about multi-species justices and stuff. So the environment and the more than human and sustainability are very much part of that. So let's see if I can sort of get in there with my reproduction angle. So that would be fun too. Yeah.
So you talked a little bit about the Sami population in terms of coerced sterilization. We have something very similar to Canada.
I think,
Yes, and we have a group that's looking at, and they have actually looked at providing ART services to survivors of coerced. So I was just wondering, is that something that Finland has ever thought about?
No, probably should. No. But that again, I guess, like sort of announcing ourselves as, there's social equality and there's this care and everybody gets equal access. It's easy to hide behind that, well, you can too get assisted reproduction just as easy as everybody else, which is not true for many reasons, some known and some not known. One of them also, because there is also city Sami in Finland, but like there is still a lot of people living up north and also sort of struggling to still sort of live by, the traditional means of livelihoods, really sort of nature bound. And the distances to like assisted reproduction from there is already ridiculous. So in that sense, well, just one other reason for, them probably not gaining equal access. And then again, that like just to give them access would be, I don't know, not really acknowledgeable policy in the sense, given that the Sami understanding of kin and family is not this like really biogenetic type of way at all. So to say that like let's get you a nice donor so you can get somebody that looks like you, and it's probably not cut it much. So
For us here, the government actually gave money to.
that's interesting.
Yeah, and then we did the study to look at all the options across Canada, in the US and other places in Europe, and Latin America as well. And so they wanted a report on what were the available services first, technology and any donation surrogacy, in vivo, in vitro. And so they were saying they wanted the options, and then the government was going to pay for the options. So, yeah.
But yeah, it's obviously not a bad thing at all. Yeah, like of course, like when you think about reproductive justice, access is important, but you cannot stop there. And also, but because they are talking about like the end of resilience up in Sami, because obviously the climate change, like all of sort of Arctic areas, is hitting the Arctic areas worse, and because a lot of the traditional livelihood involve reindeer herding, and the baths are destroyed pretty much. They can't herd the reindeer anymore. There's no there's no food for the reindeer during these like the old paths they go, and it's just devastating in many ways. So, and it's not just climate change, it's the energy industry, the mining and stuff. So they're just really talking that it's the end of resilience and last generations of Sami, not necessarily meaning that they will be physically all dead, but like there's the culture will die, and then the connection to the land. So that's quite devastating. So we can obviously see that something, but we can give you IVF. It's probably not going to cut it.
Anything about the environment?
So here's IVF. Yeah.
I think we have time for one more question before.
Okay. One more question.
What's next in terms of the research project?
Oh, that we're doing right now. Yeah, so we a year and a half in. I have one PhD student who started right from the beginning, and well, they're now on their parental leave, but she's already collected some interviews from women that are thinking about or have gone through egg freezing. And also, cis and trans women are her interest, because we're interested in sort of looking at the variation of gender, in addition to thinking about it intersectionally, and women that use the fertility apps. So she's sort of looking at them together with probably the framework of conceptions of anticipation and whatever else turns out to be sort of interesting in the data. And she'll probably be going to the clinics also for observation of and interviews around cryopreservation mainly, and obviously how AI might, because that's the thing, AI is also being, well, I think it's already developed that like, but it's not quite clear whether in EU or if FDA, is it the same here that approves whether health tech,
it's the health protection bill.
Something similar. If those will go through, but the idea is that according to the advocates and the industry, is that cryopreservation would be totally done with robotics, and that's like the boring stuff for the embryologists. So like surely this can be just done with machines, but it's not, to my knowledge, taking place really right now yet, but like everything's ready for that much I know, and there's a lot of experimental stuff going on now, AI. Also, I guess a little bit linked to what was asked from the audience online. In in an effort, at least like that's a marketing talk, because we know that there's in an effort to standardize and automate so that like they can branch out and make more money, but also to make the treatments more affordable. And I'm not saying that won't happen at all or anything, just trying to raise the critical voice here, I suppose, talking, that like if patients could sort of like measure their own endometrium, they are developing like apps and devices for that, and then they wouldn't have, or like ultrasound that you could do at home out for the, well, it is kind of endometrium, ultrasound type of thing with the endometrium, so that they could with that tech sort of also predict at the clinic like the ideal window for transfer, because they also think that this is maybe something that they haven't yet noticed that's important in IVF. It's so that it's not transfer for everybody on the day 3 or day 5, but it's more individual than that. So if that works, yeah, like you don't have to go to the clinics, you don't, especially if it's like really long ways, and surely that will then be something that makes it more equal, but in a larger picture. We'll see what happens. So
DIY fertility.
I guess like that's part of the, yeah, that's just, that'll be the cheapest, I suppose, for like a clinic thing. Just like, here you go. And yeah. But yeah, it's that. Thank you so much. Thank you for your great comments and questions.